right, thanks for coming. We're going to talk about proximal humerus fractures today. So this is the first case, 85-year-old man with a slip and fall, and here is his injury. So Ed, what are your thoughts? 85-year-old woman, I'm sorry.
Two good views. First,
all right. You're high maintenance. You're high maintenance, but here you go. Here's an AP,
to judge.
And here's a lateral. AP lateral. Real case, came through last week. 85-year-old woman, lives by herself, very alert, oriented, community ambulator.
Yeah.
She goes to bingo, and she's active in her church.
Send her to the office.
Send her to the office. What do you do in the office? What are your thoughts about the fracture? Because Megan's like, what is that?
Manage it conservatively.
Okay, so immediately you say non-operative treatments, but something went through that little brain of yours to make you think that. What made you go through your brain?
Position of the bones.
So the bones are reasonably lined up, right? Very minimal displacement. Okay. Comminuted, not comminuted? Not too comminuted. Although there are several fragments here.
Not to worry about.
Okay. And the tuberosities, are they involved, you think?
No.
Okay.
Not that I can say no.
This is probably the greater trope, right? But it's not minimally displaced.
Right.
And the lateral view, it's a little bit retroverted, isn't it?
Yeah, but she probably has a giant rotator cuff tear too.
Mm-hmm. Okay.
It's been there for 20 years.
Okay. So all these things, like things going through your mind, and Megan's like, what made him think all that? There are different parts of the shoulder, and if you can break it down, there's four general parts. There's the head, the humeral head part, and that part has a limited blood supply. There's the two tuberosities, greater and lesser tuberosities. On the greater one is the rotator cuff. On the lesser, the subscapularis. And then there's the shaft portion of the humerus. And on the shaft, the latissimus dorsi, and the pectoralis major go to that, and that's what pulls it apart. The blood supply comes mostly from the anterior circumflex artery and goes up the arcuate artery. But in most fractures, this is torn. Almost all fractures, I think this is torn. And we're going to get over that. And probably the reason why some die and some don't is from the posterior circumflex. So how much of the humeral head is from the anterior circumflex? Everything that's not shaded is anterior circumflex. So most of the humeral head comes normally from the anterior humeral circumflex. So here are the x-rays that Ed wants. Here's the
That's what I yell at them to get.
Grashey View. How do you ask for it?
I want a true AP.
Do you say true AP? I say
AP,
Grashey View. Yeah, I say Grashey View. That makes them open the book up and see what it is.
Fine, but if I just say true AP, I want to see the glenohumeral space.
I know what you're.
They have to go perpendicular to the plane of the scapula.
Yeah, I know. So it's like 30 degrees off. But if this is my point: is that you got to get the thing done somehow. And how's this person going to figure it out? You don't know who that person is. There's always different people. So I always say Grashey View, and they have to look it up in a book.
Okay.
I mean,
you should be able to look up a true AP as well, but that's what I want. That's what you want.
And the scapular Y view. And here's in the true AP.
Most of the time, the emergency room doctor will not get good X-rays, have no clue what they have, and they get a CT, and not go to an X-ray.
They don't even look at the X-ray. They look at the radio. They look at the report. They don't even look at the X-ray. So here's you can see the greater troch and the lesser troch's right here, and you can see the glenohumeral joint real well. And on the axillary view, you can see the lesser tuberosity. I meant to say tuberosity.
This isn't very comfortable to get.
Axillary view?
Not they won't usually let them.
They don't get this in the ER, but an orthopedic surgeon, you have to hold this to get it because the patient has a lot of pain. So on the axillary view, you can see the lesser tuberosity, and what's most important is you can see if the glenohumeral joint's located. But like I said, the CAT scan, you can see the fragments, you can see the articular surface, and you can see exactly how displaced the tuberosities are. How often do you get CAT scans, and why do you get CAT scans, Ed?
I can't visualize what I think the pattern is of that CT.
Okay. So who is non-operative proximal humerus fracture? Well, most proximal humerus fractures are non-operative, 80%. But some of them are displaced and then need surgery. So what makes you decide for surgery? Well, there's the fracture pattern, whether the head's going to be viable or not, the bone quality, what implants you have, and patient age and comorbidities. Hey, good morning. Good morning. Dr. Bill, Dr. Dinkar, Dr. Doug. We're just going over proximal humerus fractures. So just to review quickly the x-rays, there's the anatomical neck, which is basically, I think, the cartilage, where the cartilage stops, the humeral head, and then there's a surgical neck, which is basically, by definition, a surgical neck is where, just below the tuberosity is where the humeral metastasis starts to go into diaphysis. And this is where the joint capsule is mostly. So those are kind of the two most important anatomical structures on x-rays. And the other just important thing is the rotator interval where the biceps tendon runs, and the two most important, the important deforming factors are the, like Ed said, he's always thinking rotator cuff. The rotator cuff is on the greater tuberosity than the subscap, and you can see how large the pec major is, and the latissimus dorsi there on the shaft, and these are all deforming forces. The other important thing to remember is the brachial plexus is closely associated with the shoulder, and also the axillary nerve goes posterior to the humeral shaft. And when you manipulate these shoulders intraop, you can cause a brachial plexus palsy. So Codman was the first person to break it down into fragments, and there's basically four pieces: the two tuberosities, greater and lesser, humeral head, and the humeral shaft. Okay, and also all this lecture came from the Orthopaedic Trauma Association. So now this is I know everybody read this whole article, especially Doug, because he really gets on my case when I don't send articles, and then he never reads them. But this is from Hertel's article in 2004 on head viability, and the way he broke it down is these are Legos. Bill, did your children play with Legos? All the time. Yeah. So these are Legos, and this study was done in Switzerland. So he used Legos, and this Lego is the humeral head, this Lego is the greater tuberosity, this is the lesser, and this is the shaft. And you can see all the different variations of fractures, and you can use Legos to understand the different types of fractures you could have by using Legos. I mean, it's a little bit of a joke, but you understand the concept that there's all sorts of different variations. And this is the article, but basically this person took 100 heads, 100 humeral head fractures, proximal humerus fractures, and he studied them by drilling a hole in the humeral head and seeing if there's backflow. So in intraop, he took a 2.5 millimeter drill bit and drilled into the humeral head and see if there was bleeding. If he couldn't see bleeding, he had a Doppler that he stuck in there, and if he heard the swish sound, he knew the humeral head had blood flow. So he checked which humeral heads had blood flow and which did not, and what predicted that to help. So these are the questions for every case, and they're binary questions, yes or no. Is there a fracture between the tuberosity and the head? Is there a fracture between the tuberosity and the shaft? So you can understand basically describing the pattern. And this person who wanted to see if the people are at risk for AVN. So if you don't have blood supply to the humeral head, you can get AVN. And then the other question is humeral head AVN a big deal? What do you think, Bill? Is humeral head AVN a big deal, or you don't care? Or can you live with it? Can you throw baseballs?
An isolated defect, probably not. You get collapse of the whole head. You're just going to have osteoarthritis.
So pain and stiffness of the shoulder, and the shoulder doesn't work well. Okay, and this study they studied all the humeral heads, and they said, what did they find? They found that displacement of the fragments was really not that important, and whether it was dislocated was not that important. What was important was if this medial hinge was off. So in other words, if the humeral head was lateral and the medial shaft was medial, that was a very predictive factor. And the other one is whether there was a metaphyseal extension to the head. So if the head had metaphysis to it, it's more likely to live. And the reasoning was the humeral heads that live are the ones that have an intact posterior circumflex artery. So the working hypothesis is when you fracture humerus, everybody loses the anterior humeral circumflex artery, which is usually what gives you blood supply. But the people who had an intact posterior circumflex still had blood supply. So it's predicted by these two things.
You would think in the one on the top right that it wouldn't lose the anterior. What's going to compromise it? You know, in that pattern, you see it quite a bit.
Right. Well, no. Well, the thing is, it's an interhumerus. Look, every single time I think the ascending arcuate artery gets torn. Let me show you.
Just thinking about that pattern and whether that's really going to happen.
See this thing? This thing probably gets torn every single time in proximal humerus fractures.
The arcuate. What,
Yeah, this is what I mean. The blood goes right to the humeral head. So this is where the blood comes from. So that's the point. Is like that these people make is like every single time that's ruptured, and that's what gives almost always all the blood supply in a normal case. But in the heads that survive, they have an intact posterior. So normally it's not the main blood supply. But it's what works. I mean, so they say almost every single time this gets torn. All right. So this is a case that's torn. So there's no medial hinge. The shaft is medial to the humeral head. And this is at risk for AVN of the humeral head. Now this is a case that should live, even though it's very comminuted and even though the fracture is displaced, the humeral head should remain viable because there's 8 millimeters of metaphyseal extension. So it's kind of counterintuitive. And the other important thing with humerus fractures is how thick is the cortex. So this is another study where they just measured the cortex in 4 areas of the humeral head, and if it's less than 4, if it's average less than 4 millimeters in these 4 areas, they're at high risk for cutout of any kind of implant. So, does anybody want to know exactly where they're measured? It's where the shaft metaphysis becomes diaphysis, and then 2 centimeters below, and you measure the cortex at these 4 points. And if on average it's 4 millimeters or less, that's not enough to hold screws. That's their point. It's a very high cutout rate. So just look at the cortex, I guess. And then when they fail, these implants usually fail in varus. But now with locking plates, it may not be the case. So this is just a protocol of how to treat these cases. And it goes by either if it's a 2-part, if it's a 3-part, or if it's an anatomical neck. And then this is from the HSS protocol. And then they measured the cortex to see how thick it is, what to do. And they also measured how much it was displaced. And their definition of displacement was 2/3. If it's displaced by over 2/3, it changes what they do. So let's do the first one is the 2-part. Non-operative treatment, if it's moderately displaced, less than 66%. And they followed these, and they felt that non-operative treatment was just as good as surgery. So non-operative treatment has usually good or excellent results, 77%. Okay, here's case 2. This will be Doug's case. A 58-year-old woman, right-hand dominant. She fell on her arm. Here's the x-rays. What do you think, Doug? Can you explain it? What's going on? Fragments? What's going on to your head?
It looks like
She has Blue Cross Blue Shield, by the way, too.
she's got
I made Bill laugh.
greater tuberosity fracture and a surgical neck fracture,
Uh-huh.
and probably a lesser tuberosity fracture too. So she's sort of got a
This is the lesser tuberosity, right?
Yeah.
Would you say?
So she's-
There's one more view, too, before you go on. Here's a scapular Y. Let's do the criteria we just learned. So is the medial hinge intact? It is.
Does appear to be intact.
Is intact, yeah. So it's not. The head is actually medial to the shaft. And how about metaphyseal involvement? Can you tell?
Does not appear. to have
Yeah, it doesn't appear. So that's not a good predictor for her. And also, she's got a fracture. This may be an anatomical neck fracture here too. It's kind of high.
Right.
But she's all, I mean, it's comminuted. So what would you do in this case? You think it's at high risk or non-op? What are your thoughts?
I think she would be a consideration for a hemiarthroplasty. I think that because of her tuberosity displacement, she's an operative. She's an operative candidate. She appears to have pretty good bone. So
Cortex looks pretty thick here, doesn't it?
yeah. So I'd probably image her, but I would give consideration to fixing her. But if the CT showed much intra-articular displacement, I would give consideration to replacing the joint.
Okay. So what was the final verdict?
What was the final?
Non-operative?
No, it should be operative.
ORF? Sutures? Or hemiarthroplasty?
I might try to fix her.
ORF? Will anybody do anything differently? Hemiarthroplasty?
Fracture.
4-part fracture?
Hemi.
So you feel that the humeral head is destined to die?
I think it's falling apart. It's not going to.
Too comminuted to fix?
Not going to work.
Humeral head might live, but I think she's
Doesn't
going to have
matter.
terrible function.
Function's
The
gonna suck.
tuberosity's off like that. She's
Mhm.
not able to duct at all.
Mhm.
Stink. Sorry, it's going to stink.
Okay.
What was done?
Nothing, I don't know, I'm just asking. So the approach is delta pectoral groove usually. Do you guys use any other approaches?
Sometimes I'll use a deltoid split
Deltoid splitting, lateral,
to get to other parts, like to a greater.
greater tuberosity.
Yeah.
Mhm. Okay, so
Sometimes you have to use both. You can't.
use both.
You can't. Yeah.
You know, that's a 4-part, but you know, when they talk about parts, they talk about displacement also, and really the head is not displaced from the shaft on that.
But it's
It's
45
rotated.
angulated.
It's rotated at least 40 to 60 degrees, though. Absolutely.
Displacement, all right.
It's facing the chromium. It's not facing the clinoid. It's facing north.
Whether to operate or not?
Yeah,
Just
when they
treat, I
talk
mean, if
about
you treat that
parts,
non-operatively, I would assume that greater tuberosity is,
It's facing
it's gonna,
north,
she'll have
not-
severe impingement. Okay, in this protocol, if the bones were weak, less than 4 millimeters, they treated it with either heavy suture or a locking plate. If the bones were strong in the HSS protocol, they did percutaneous pinning. If they were displaced, they did ORF. If the quality of the bone was poor and it was a 3-part fracture, but minimally displaced, they treated it in a sling. So if people had poor bone, there was a very high failure rate with standard plates, but apparently locking plates have changed that. Have you guys found that to be the case? So here's looks like mostly a 2-part fracture, but it's displaced significantly. And they did looks like a deltoid, I'm not sure, did a locking plate. Hemiarthroplasty in the HSS protocol was for highly displaced fractures, 3 or 4-part, poor bone quality, and they felt it was not reconstructible. You couldn't put it together, which is what you guys kind of explained. So very osteoporotic, multiple pieces, very comminuted, is better treated with a hemiarthroplasty. But in general, hemiarthroplasty, although the pain relief is good, the function, lifting your arm over 90 degrees is very poor. What do you guys think about that? You think that statement's true in practice?
Yes.
These people serving overhead after you fix them?
They're good down here.
Huh?
They're good down here below.
Yeah.
Go on the walker.
Yeah.
They're tough to rehab, aren't they, Megan?
They are,
Because you can't push them too hard early,
right.
tear it apart.
I-
And then
You're
they
stuck.
fibrose in.
You're stuck.
Yeah.
Well, when do you guys start active range of motion? Like 6 weeks? Or? So everything's passive, right? Until 6 weeks?
Pretty long time.
I see very poor outcomes.
Well, usually the bone is so bad that even with good fiber wire suture fixation, you move them, you can see that
It's
it
moving a
almost
little
starting to
bit
cut out.
when you're done. Right.
All right, let's try another case. Case 3 is, and these are just, I only have x-rays, I don't have results, so it's just for stimulation for discussion. Case 3, Bill is a 42-year-old, the male, the fall from 16 feet, and here is his x-ray. That's the only film I got. What would you do in this case? Like, let's try to predict if the head's going to,
Curiosities look off, the head is impacted.
so it's a 4-part fracture, right?
More than 45 degrees. The axial hinge may be.
So it's medial. So by definition, this may not be viable on this, and also, but he does have some metaphysis here.
Right.
42-year-old guy.
42-year-old guy, I might try a locking plate with this guy.
42 is young because it's younger than you, right? That's the definition. So,
Right.
so you would do an RIF locking plate.
I might try a locking plate.
What else would you do? I mean, if you don't do a locking plate,
I mean,
Hemi, right? There's nothing else. You can't do percutaneous fixation.
I'd argue that.
Okay. So with the HSS protocol, anatomic neck fractures have a very high rate of AVN. Unless they're fixed anatomically, it may be a good idea to treat this with a Hemi. And if it's poor bone, a Hemi. So young patients, what's your Jack? What's your definition of young?
Gets older every year.
What? Right. Age minus 5 years, right, is young. Your age minus 5 years is young. So for young people, preservation of function is a primary objective, full court press, anatomic fixation, stable fixation, and only hemiarthroplasty if you cannot reconstruct it. So for elderly people, which is by definition your age plus 5 years, it's for bone quality and pain relief is the primary objective. So hemiarthroplasty, early motion. So case 4 will be Jack's case. It's a 28-year-old man who was involved in an altercation at Looney's Pub. We won't get into the details of the altercation, but the result is this fracture. So what are your thoughts about this fracture? What would you do? Like, describe the fracture for everybody, and what would you do for it?
Well, you've got two things. One, you've got medial displacement, which makes his risk.
So he's a little bit at risk, right, by definition?
Then you've got anatomic head fracture, which is also a risk.
Yep, looks like there's a fracture through the anatomic neck.
So you've got two negative predictors.
Mhm.
But
How about medial extension? It's hard to tell. Remember the medial hinge extension?
that's pretty minimal.
Hard to tell, yeah.
So I think, this guy has a high rate probability for AVN,
Mhm.
but he's 28 years old. I think you try to fix this one, and if you can't, then if it dies or something like that, then you go and replace it. But I think your first shot on this guy ought to be to fix it.
So would anybody do anything differently?
Or you just treat it close.
Non-operative?
I would not.
Non-operative.
Non-operative?
Non-operative.
So 3 out of 4 non-operative?
Total later.
I would do non-operative only because I'm a spine surgeon and I'm not interested in doing shoulder surgeries. Okay, so physical therapy. Megan, what's your approach to physical therapy in these cases?
Well, they're usually very painful. Get them moving early, pendulums.
Let me ask one question. Bill, when you do ORAF, what do you write in the prescription? Just physical therapy, evaluate and assess, or do you have a protocol?
It depends who I'm sending it to, but.
Let's say
usually,
Megan.
Megan. I'll say passive motion.
Passive motion for 6 weeks?
Passive motion times 4 weeks.
Okay, passive motion 4 weeks to Megan, and then go crazy. So
Some
Megan,
of them I'll let them do passive for 2 weeks and then assisted active for the next 2 weeks. Because they're doing assisted active anyway, even with passive. Most of the old folks try to do it for you.
They do.
so what do you do, Megan?
Pendulums, usually circles. Then I give them, you would do pulleys, passive motion.
Pulleys are passive.
Pulleys are mostly passive.
Okay.
If you can really cue them correctly. I do a lot of just range with them. I don't let them really do a lot on their own.
So you hold the hands, everything's passive.
Yep.
Okay.
Hold their hand.
Okay, last case, adds a 93-year-old man who fell off his tractor and has this fracture. What are your thoughts?
Get on the horn.
Send it to shock trauma?
Yes.
Okay. So it's a large metaphyseal spike, very comminuted, the whole shaft's involved. But the metaphysis is involved, and there's no, the medial hinge is intact too, so the humeral head should live. This shows that it's comminuted. In this case, it was obviously done at a trauma center because it's got this really long locking plate and it spanned the whole fracture. And as usual, everything heals in these cases. So thanks. So any questions or comments or thoughts, Doug?
No thoughts in there.
Jack, huh?
So no thoughts in there.
Okay, that's it. Humeral, proximal humerus fractures. Thanks for coming.